This is an introductory lecture about visual evoked potentials. It is intended for the clinical neurophysiology fellows at Nicholas Children's Hospital. It will be conducted using a question and answer format. The first question is, to read visual evoked potentials, you only need to know about brainwaves. A, true, B, false. To read and understand visual evoked potentials, you must know about stimulation devices, computer settings, brain wave interpretation, visual fields, eye anatomy, and visual pathway anatomy and physiology. So the answer to this question is B. Next question. Which is the unit for visual fields? A, degrees and minutes, B, centimeters and millimeters, C, square millimeters, D, any of the above. Visual fields are measured in degrees and minutes. The extent of the visual fields are limited to about 60 degrees up by the forehead, to about 75 degrees down by the cheekbones, to about 60 degrees medially by the nose, and to about 100 degrees in the temporal direction by the anatomical configuration of the orbit. So the answer to this question is A. Next question. Retina can be mapped out in relation to the visual fields. A, true, B, false. Visual fields can be extrapolated to the retinal bed. In this figure, I have placed a white dot on the fovea. And now remove the eyeball, leaving only the white dot representing the fovea. I have done this to indicate the 0 point from which other areas of the retina are mapped out. In this frame, you can see the curvilinear yellow lines representing the back of the ocular sphere. The white line I have just introduced represents 1 degree. 1 degree is equal to 60 minutes. The new line represents 10 degrees from the fovea, now 30, now 45, and now 75 degrees. 75 degrees corresponds to the extension of the inferior visual field. I am going to do the same thing in the lower retinal segment. Notice that the furthest point from the fovea with visual field elements is 60 degrees, which corresponds to the 60 degree of extension in the upper visual field. As you can see in this frame, I have added lines in the perpendicular axis corresponding to the temporal retina. The furthest line from the fovea is placed at 60 degrees, corresponding to the extension of the nasal visual field. Now I have added white lines on the other side of the perpendicular line. the furthest representing 100 degrees. This corresponds with the extension of the temporal visual field. So the answer to this question is A. Next question. The visual angle in minutes of arc is equal to check width divided by the distance from the eye to the screen multiplied by the arcing. A, true, B, false. The visual angle is the angle a view object subtends at the retina. This is usually stated in degrees or minutes of arc. This bunch of statements that I have just introduced in this frame are from the guidelines written by the Academy in 2009. As you can see, the visual angle is equal to the arcing multiplied by the width and divided by the distance. This can be approximated for small visual angles by the formula being pointed by the arrow. This formula states that the visual angle is equal to a constant multiplied by the width and divided by the distance. The constant when using minutes is 3,438, and when using degrees is 57.3. I think I can make it clearer. As I have just mentioned, the visual angle is the angle a viewed object subtends at the retina, usually stated in degree or minutes of arc. If a person looks at an object that is 1 centimeter at a distance of 1 meter, the object will create a retinal image that will occupy 0.57 degree of retina. This corresponds to more or less 0.17 millimeters of retina. If the same person looks at a 2 centimeter object at a distance of 2 meters, the retinal image will be the same, 0.57 degree, which corresponds to about 0.17 millimeters of retina. In other words, it would be the same as in the prior example. If a person looks at the moon, the image of the moon will occupy 0.52 degree and be represented by 0.15 millimeters of retina. So the size of an object represented in the retina is directly proportional to its actual size and inversely proportional to the distance from the nodal point. But in order to convert this to degree or minutes, we need to multiply the size of the object by a constant that, as we previously mentioned, and it's also mentioned in the guidelines, in minutes is 3438, and in degrees 57.3. The use of 3438, that is 3438, works better for very small areas, so it is often used for checks. The use of 57.3 works for very small areas as checks, and also for slightly bigger areas such as fields or checkboards. I am going back to the initial example of an object 1 centimeter wide, 1 meter away, to show you how it works mathematically. So the visual angle of a 10 millimeter check view from 1000 millimeter distance is directly proportional to the size of the object and inversely proportional to the distance from the eye to the objects, as we have just previously mentioned. And also as I have just mentioned, in order to determine the degree of arc, we must multiply the size of the object, that is the size of the check, by 57.3, which will get us to 573, which has to then be divided by 1000, which, rounding it, would be equal to 0.57 degree. To determine the same thing but in minute of arc, we do the same operation, but this time using 3438 as the constant, which yield 34,380, which then is divided by 1000, which correspond to about 34 minutes. It is easy to convert degree to minutes by multiplying the degrees by 60, and it is also equally easy to convert minutes to degree by dividing the minutes by 60. This is the second example I gave you. I show you this example because I would like you to work out the math of it on your own. In this frame, I have worked it out for you. I hope you have worked it out on your own before, but if you haven't, please take a few seconds to look through this frame and make an attempt to get to the right number. So the answer to this question is true. Next question. If you want to use a check with a visual angle of 30 minutes and a screen is 1 meter away, how many millimeters wide should the checks be? A, 8.8, B, 11.6, C, 24.6, D, 30. In this question, you have the minutes and the distance. So the easiest way to go about doing this is to convert the minutes to degrees, then to multiply the degrees by the distance, that is by 1000 millimeters, and then divide it by 57.3. The result is 8.7. So the answer to this question is A. Next question. Checks are usually measured in minutes, checkboards, and fields in degrees. A true, B false. This frame has values of commonly used checks and boards. Check values are usually given in minutes. Checkboard values are usually given in degrees. So the answer to this question is A. Next question. The clinical macula and the histological macula correspond to the same area of the retina. A, true. B, false. I am showing you this complicated figure and a sketch of the retina because some textbooks about visual evoked potential use this terminology. Notice that the macula is defined in two different ways. The arrow in this figure points to the macula, referring to the histological macula. The histological macula corresponds to the region of the retina which surrounds the fovea. The boundary with the rest of the retina is histologically defined by the transition from a two-neuron ganglion layer in the macula to a single neuron ganglion layer in the peripheral retina. The macula, so defined, has three components: the perifovea, the parafovea, and the fovea. The histological macula has a diameter of 5.5 millimeters and covers a visual angle of about 18 degrees. The clinical macula, that is the red area we usually look and see with our ophthalmoscopes, is in reality the fovea, where cones are present without any ganglion cells. Yet still, despite the fact that there are no ganglion cells, it is considered part of the histological macula. The fovea has a diameter of 1.5 millimeter and subtends a visual angle of 5 degrees according to some authors and 3 degrees according to others. The confusing point is that histological fovea is often referred by us clinicians as macula, and when we talk about visual fields, we refer to the area with the highest visual acuity not as the foveal area, but as the macular area. So the answer to this question is B. Next question. Cones are primarily found in the fovea. A, true. B, false. This structure represents a horizontal cut of the eyeball through the equator. The structure indicated now by the arrow represents cones per square millimeters. The column indicated by the arrow, that is the y-axis of the chart, indicate the number of visual elements per square millimeters. The y-axis corresponds to the retinal bed at the level shown in the diagram of the eyeball. As you can see, at the level of the fovea, cones are maximally expressed. Their presence drops sharply as the distance from the fovea increases, as you can see in this frame. And this occurs in both directions. But still, a significant number of cones are present in the parafovea. Cones are responsible for photic vision. The blind spot obviously does not have any visual elements. So the answer to this question is A. Next question. The largest component of rods are in the parafovea. A, true. B, false. This is the same figure I just showed you regarding cones. The new element I am introducing here represents rods per square millimeters. As you can see, the distribution of rods is quite different from the distribution of cones. The maximal concentration of rods are in the parafovea region. The parafovea region surrounds the fovea, and at the level represented in this figure, which corresponds to the cut through the equator of the eyeball, the parafovea is interrupted by the blind spot. The rods are responsible for scotopic vision. So the answer to this question is A. Next question. Animal studies support that there are two types of ganglion neurons. A true, B false. This is a cartoon representing the fovea and parafovea. The fovea is where the cones are, the parafovea where the rods are. The neat separation I have represented here between the locations of cones and rods is, as you know, not as cut and dry as I have represented in this frame. Anyway, light comes in, hits the pigmented epithelium, cones and rods react, retinal neurons become active, and send signal to the ganglion cells whose axons constitute the optic nerve. There are three types of ganglion cells. One type is called X ganglion cells. This type receives information from the cones. Their field have lateral inhibition. They serve the area of the fovea, which, as you remember from our previous conversation, is the structure we usually call the macula. Ganglion cell X hardly discharge when the retina is exposed to moving objects, thus are said to be or to have low sensitivity to object movements, but are very active when the retina is exposed to patterns. A second type of ganglion cells are the Y ganglion cells. They are larger than the X ganglion cells. The Y ganglion cells receive information from the rods, and apparently not all their fibers are involved in the lateral geniculate occipital pathway. Some of their fibers are involved in a different system that takes a more far and convoluted course to reach different areas of the cerebral cortex. The ganglion Y cells are not involved in lateral inhibition. They serve the area outside the fovea. This type of ganglion cells discharge at high frequency when the retina is exposed to moving objects, so we talk of them as being highly sensitive to motion, and they are hardly active when the retina is exposed to patterns. The third type of cells are the W ganglion cells. They are connected to rods. Their receptive field is not well known. They are found in the peripheral retina and probably not involved with vision. So the answer to this question is B. Next question. Which of the following ganglion cells are involved in the pupillary reflex? A. Ganglion cell X, B. Ganglion cell Y, C. Ganglion cell W, D. All of the above. On the left side, you can see a cartoonish representation of the visual pathways. And on your right, the different type of ganglion cells. The axons of the X ganglion cells go from the retina to the lateral geniculate. The neurons at the lateral geniculate send their axons to the primary visual cortex. The axon from the X ganglion cells and from the lateral geniculate constitute the main visual pathway. Axons from the Y ganglion cells probably take different routes. Some go to the lateral geniculate. Neurons from this nuclei reaching the primary visual cortex are part of the primary visual pathways. Yet other axons from these same ganglion cells go to the pulvinar nucleus of the thalamus. The smallest ganglion cells, that is the W ganglion cells, make contact with neurons in the hypothalamus at the level of the suprachiasmatic nucleus, and they also send axons to the superior colliculi and other tactile nuclei. The W ganglion cells are involved in the pupillary reflex. So the answer to this question is C. Next question. The only pathway from the retina to the cortex is through the lateral geniculate ganglion. A true, B false. Neurons from the pulvinar nucleus that initially receive axon from the ganglion Y cells in the retina have connection with the parietal cortex. So the answer to this question is false. Next question. Cortical processing of visual information only involves the occipital and the parietal cortices. A true, B false. In addition to the occipital and parietal cortices, the inferior temporal cortex is also involved in visual processing. So the answer to this question is B. Next question. How much of the primary visual cortex is used by the clinical macula? A 1/3, B 1/10, C all of it, D none of the above. This drawing represents the principal visual pathway. The area in yellow represents the area of the occipital cortex involved with macular vision. This area represents 1/3 of the primary cortex. So the answer to this question is A. Next question. Which of the following montage is most often used in the United States for visual evoked potentials? A. Queen square system, B. 10-20 system, C. rectangular system, D. circular system. Two types of montage are used for visual evoked potentials. One type is used primarily in England. It is called Queen Square. Labeled by the Academy demonstrate that this montage is superior to all the other ones being used. The other way was initially used in France and is called the 10-20 system. The steps for electrode placement when using the Queen Square system, which is the one most used in the United States because it has demonstrated better results, consist of using two landmarks, the Nation and the Inion, measuring 5 centimeters up from the Inion, which usually ends up being about 1.4 centimeters above O2 when we use the 10-20 system in the adult, and labeling the spot MO for mid-occipital. From this spot, we go 5 centimeters forward at the same level and mark another spot. This spot is labeled LO for left occipital. Then we go forward 5 centimeters more and label that spot LT for left temporal. Then we go to the Nation and measure 12 centimeters up and label the spot mid-frontal. Then we go 5 centimeters back from there and label another spot MP for mid-parietal. The last spot we label is the vertex that we would use as ground. Next, we place electrodes at all these locations as I have done in this frame. Notice that it includes an electrode in the inion. Electrodes are also placed at the ears, lobes, or the mastoid, and they are labeled A1 for the left and A2 for the right. In this new frame, I have changed the view of the brain. Instead of showing you the lateral hemisphere, I am showing you the mid-sagittal view of the brain. I have done so to show you the position of the calcarine fissure. Advocates of the Queen square system argue that the placement of these electrodes in this location is better suited to monitor the calcarine sulcus than using the 10 to 20 system, and the Academy seems to agree with that assessment. These electrodes are combined to make two montages, as you can see in this frame. Montage 1, that is regularly used, is the montage in which the occipital electrodes are referred to the midfrontal electrode. And in addition, a fourth channel is used to connect the midfrontal electrode with one of the ears. In this case, the left ear. The second montage connects the inion, mid-occipital, mid-parietal, and mid-frontal electrodes to a combined ear reference. This montage is used if the first montage shows no identifiable or clear wave patterns. Looked from above, the occipital electrodes, when we use the Queen square system, looks as you see here. The steps used to place the electrode using the 1020 system was described on one of the videos regarding EEG. Anyway, when we look at them from above, there's really not much difference between the Queen square system and the 1020 system. So the answer to this question is A. Next question. Visual evoked potentials require less amplification than brain auditory evoked responses and somatosensory evoked responses. A true, B false. VEP requires 20,000 to 100,000 amplification. Brain auditory evoked responses and somatosensory evoked responses require much more. Remember that we can see photic responses to light in the regular EEG. So the answer to this question is A. Next question. Which of the following is desirable for visual evoked potentials? A. Filters 1 to 100. B. Impedance 100 ohms to 5000 ohms. C. Inter-electrode impedance difference of less than 20%. D. All of the above. The recommended filters are low frequency filter 1 Hz and high frequency filter 100 Hz. Low frequency filters should have a roll-off of 12 or less dB per octave. High frequency filter should have a roll-off of 24 or less dB per octave according to the International Society for Clinical Electrophysiology of Vision report, which was published in 2010. The use of filters as specified will produce a window restricted on one side by the low frequency filter of 1 Hz and on the other side by a high frequency filter of 100 Hz. 60 Hz notch filters should not be used and are not recommended. In this new frame, I have moved the high frequency filter to 200 Hz as some of the authors have advised. Such a move expands the window, allowing more high-frequency signal to contribute to the ultimate wave. The electrode to be used are the same as those used for EEG. Silver chloride are probably the best. The impedance should be kept between 100 and 5,000 ohms, and no more than 20% difference in impedance should exist between any pair of electrodes. So the answer to this question is D. Next question. Increasing the low frequency filter decreases the peak latency. A true, B false. In this figure, we have set the low frequency filter to 1 Hz. By decreasing the low frequency filter, we allowed more slow waves to contribute to the ultimate wave that we will see in the monitor. By increasing the low frequency filter, we allowed less slow wave to contribute to the ultimate wave that we will see in the monitor. Let's start by talking about what happens when the low frequency filter is increased and less slow waves are allowed to contribute to the ultimate wave. I have schematically represented here an ultimate wave in red being produced by 2 waves, a faster wave in yellow and a slower wave in green. The arrow above indicates the direction of time. If we increase the low frequency filter, we remove the slower wave, thus changing the ultimate wave by decreasing the peak latency and also decreasing the amplitude of the wave. This is called a shift to the left. So the answer to this question is A. Next question. Decreasing the low frequency filter destabilizes the baseline. A true, B false. By decreasing the low frequency filter, we allowed more slow waves to contribute to the ultimate wave. In this frame, I am representing the effect of decreasing the low frequency filter. As you can see, I have added a slow wave in blue. This wave was not being allowed to contribute to the ultimate wave before because the low frequency filter at the previous setting prevented it. When this wave adds up, not only the amplitude is increased and the latency is shifted to the right, that is, the peak latency is increased, but it also promotes line or baseline fluctuation. In this frame, we are looking at a cartoon. Notice the white rectangle, which height represents the extent of baseline fluctuation using a 1 Hz low frequency filter. In this new frame, you can see the effect of decreasing the low frequency filter to 0.1 Hz upon the baseline. The effect, as we previously mentioned, is to increase the baseline fluctuations. So the answer to this question is A. Next question. The minimum database samples needed to establish normal values is obtained by examining both eyes in dash normal subjects A10, B20, C30, D100. A score of patients, that is 20 patients, are needed as the least amount of patients needed in order to establish normal references. So the answer to this question is B. Next question. What is the unit for luminosity used for visual evoked potentials? A. Newton per square meter. B. Light decibel per square meter. C. Candelas per square meter. D. Millimeters per degree. The unit that we use for visual evoked potential to indicate light is given in candelas per square meter. So the answer to this question is C. Next question. Which of the following is not true regarding the mean luminosity of the checkboard? A. Should be on for 10 minutes before measuring. B. Measure white and black checks 3 to 4 times. C. Use a precision spot photometer. D. A tenfold increase in luminance slows conduction time through the visual pathways. The mean luminosity of a checkboard is obtained by measuring the luminosity with a photometer. This is done by finding the mean of white and black checks, adding them and dividing them by 2. How do we go about doing this? After the board has been on for 10 minutes, we take 3 measurements of the black checks and 3 measurements of the white checks. We find their mean, in this case 61 and 55, add them up, and then divide them by 2, yielding the mean luminosity. A mean photopic luminance of 50 CD per square meter is required. Between 40 and 60 candelas per square meters is accepted. Room luminosity should be the same for all recordings. Bright lights in the room should be avoided. Increased luminosity speeds up conduction through the visual pathways. So the answer to this question is D. Next question. Which of the following is not true regarding contrast between white and black squares? A is defined by the Michelson contrast. B should be more than 80%. D, center to periphery variation should be less than or equal to 30%. D should be 50 candelas per meter square. We previously mentioned the mean luminosity of checkerboard, which is done by sampling white and black checks. The process to determine Michelson contrast is the same, but as you will see, the math is a little bit different. We measure the blacks and then we measure the white squares. Then we choose the maximum and the minimum luminosity, subtract them in the numerator and add them in the denominator. Then we multiply them, that is the result, by 100 to get the percentage. I will show you in the next frames. We start by giving a numerical value to the maximal luminance and to the minimal luminance. As you can see, in this case, 63 for the maximal and 55 for the minimal. Then we execute the operation, yielding 6.7%. The Michelson contrast ratio of 6.7% is not the right amount of contrast. This should be more or equal to 80%. That is, the Michelson contrast should be 80% or more. In this case, is only 6-7%. Therefore, it is not appropriate. One more point regarding luminance. Luminance uniformity difference. Luminance uniformity difference refers to the difference in luminance that can be and usually is present in the checkerboard between the center and the periphery of the board. I am representing it here as 100 candelas per square meter in the center and 80 in the periphery, yielding a luminance uniformity difference of 20%. On the right side, I have added another board with a luminosity uniformity difference of 40%. The one on your left is fine because the difference is less than 30. The one on the right is no good because the difference is more than 30. So the answer to this question is D. Next question. Currently, most visual evoked potential stimulation protocols in clinical use are restricted to checkerboard and flash stimuli. A true, B false. In this frame, you find a small sample of the creativity of neurophysiologists and ophthalmologists in the pursuit of the perfect stimulus for visual evoked potentials. In this frame, you find the two that have survived: checkboard and flash stimuli. So the answer to this question is A, true. Next question. Which is the most common type of visual evoked potential? A, pattern reversal visual evoked potentials. B, flash visual evoked potentials. C, transient visual evoked potentials to pattern appearance and disappearance. D, steady state visual evoked potentials. Based on the nature of the stimulus, we can talk about flash visual evoked potentials and pattern visual evoked potentials. Pattern visual evoked potential can further be divided in many different ways depending on the contrast, shape, and color. You can see a sample of them in this frame. They can also be grouped according to the mode of appearance, such as simple reversal, which is the most common type used, or as onset and offset pattern reversal. Pattern evoked potentials can also be divided according to the repetition rate as transient, when each turn allows for the creation of an independent wave, or steady state, when turns occur so quickly that recognition of independent waves is impossible. This is what is called the steady state potentials. So the answer to this question is A. Next question. How are fields and checks measured? A, in centimeters. B, in minutes. C, in hours. D, in millimeters. Fields are measured in degrees, which can be converted to minutes. For most common testing, the ratio between height and width of the board should not exceed 4:3, and the dimensions should be at least 15 degrees in the narrowest side of the board. A square or checks should obviously be a square. They usually are measured in minutes. So the answer to this question is B. Next question. Which of the following factors is or are altered by check size? A, the effect of luminosity. B, the response to pattern reversibility. C, fovea stimulation. D, all of the above. The checks or square can be different size, and their size have an impact on luminance. Very small checks do not produce changes in luminance. Larger square produce changes in luminance, rendering pattern VEP as flash VEP. The manufacturers of the checkerboards have addressed this issue and modern equipment may not be subject to these changes. Another factor related to check size is their impact on pattern reversibility. Smaller squares have higher impact than larger squares in pattern reversibility. The effect of pattern reversibility is likely the consequence of fovea physiology. Small check, when vision of the subject being tested is good, produces major changes in wave as a consequence of pattern reversibility. Large squares, since they may cover the complete fovea as a homogeneous structure, produces less of a stimulus in the fovea. Larger checks stimulate the periphery of the retina more than the macular or foveal area. It is important to recognize that the periphery of the retina is less well represented at the occipital cortex than the central retina. All this boils down to a few facts. Large checks in a large field stimulate the peripheral retina. Visual evoked potentials obtained using these parameters are minimally affected by defocusing or decreased visual acuity. Small checks in small fields stimulate the central retina. Visual evoked potentials obtained using these parameters are very sensitive to defocusing and decreased visual acuity. Middle-sized checks in middle-sized fields are a good compromise for most studies. So the answer to this question is D. Thank you very much for your attention.